So next up is Professor Sandra Brown, who is going to be talking about research on addiction.
All right. Well, good morning, everyone. It's hard to follow such a comprehensive presentation as that, but I'm going to share with you some very different things this morning. And I would like to begin by first thanking the CalIT2 for putting together this series of 3 workshops that are focusing on health, and Shane for your wonderful idea to do this originally, and as always, getting funds to make it happen. And GP for the marvelous collaboration that I'm well aware of between UCSD and UC Irvine for so many years. And in particular, I would like to thank Ramesh, who, since I came to UCSD, which is many years ago, he and his predecessor have designed the Qualcomm Institute to be the place to come if you're doing very cross-disciplinary research, much of the type that I do. And Ramesh, I've marveled at his strategic procedures for moving forward and efforts. And I think this is changing even without me doing anything. Well, so that's nice. But anyway, a big thank you to all of them. It's a real privilege to come before you, and I'll look forward to the questions that you have today. Of course, these kinds of slides are always a part of what I present because I have had the good fortune to be funded by many institutions, primarily federal institutions, primarily public institutions, and none of what I'm sharing today has any conflict of interest here. So you might wonder why, after talking about older adults, we're going to shift now to younger adults. In fact, not even adults in some cases. We're going to talk about adolescents. And that is because there are 49 million people in the United States who have addictive disorders, and the cost to our country is over $36 billion per year. It's a big deal. A third of that cost goes for alcohol, and hence the area that I study. Opioids are really picking up now. It's about 20% of that. And for all of you who are working, because you all are, 11% of you across the nation, of people who are working, acknowledge that they have some type of substance use disorders. And those rates are even higher among individuals who are not working. And finally, our lifetime risk for developing an alcohol problem is 16%. So what does that mean? That means that every one of you knows someone who has an alcohol problem or a substance use problem. So hopefully, what I'm sharing with you today will be both personally useful as you think about how research can inform efforts that we make to improve these challenges, and encourage you to incorporate issues of substance use and addiction in the work that you do. So now I'm trying to get it to move, and it won't move. Let's try this. Okay. So really what I'm going to be talking about today is how addiction-related research can inform prevention and intervention, the development of those, the timing of those, et cetera. And when most of us think about studies with people who have substance use disorders or alcohol use disorders, we think about those clinical samples, people who are in treatment. But much of the work that's going on, particularly in the younger half of life, comes from community samples. And in community samples, by studying them, we can know what to expect with the engagement with substances and what may progress over time. Longitudinal studies in particular are informative to prevention and intervention studies because they help us, particularly with some new technologies like AI and machine learning, to understand new areas, new content that might be useful, things to pay attention to in our prevention and intervention programs. Also new timings. When should we talk about certain things with individuals when that accelerates their risk for progression to a substance use disorder. And in general, what are the upstream features that lead to addiction that if we attended to earlier on, it would save us a lot of money. On average, every dollar we spend for prevention in the healthcare arena saves us $7 later on. So research in this arena is particularly important. And I would say with some of the large-scale studies that I'm going to be talking about, there's another reason that longitudinal research is very helpful. And that is that the more we know about the heterogeneity of those samples, because people become addicted in many ways and there are many pathways into dependence, the more we can personalize both the prevention and the intervention efforts. And finally, because I'm standing here in QI, I also want to say that technology is one of those features that will help us make quantum leaps in what we do and how we do it when we're trying to prevent and intervene with individuals who have the challenge of facing substance use disorder. So what I'm going to tell you a little bit about this morning in the time that I have are two major projects that I oversee. One started in 2012, and it was led by the National Institute of Alcohol Abuse and Alcoholism. It's a consortium called the National Consortium on Alcohol and Neurodevelopment of Adolescents. We've studied 840 community-based youth from 5 different sites across the country, now for almost 10 years. Actually, we're on our 9-year follow-up with them. And those youth, when we started, were between ages 12 to 20. And so over a 10-year period, we will have information about a 20-year age range. And we think that's going to be very helpful. I'll give you some examples of that today. The second major project that I'm going to be sharing with you that is pertinent to the talk today is the Adolescent Brain Cognitive Development Study, the ABCD. This is the largest project that the National Institutes of Health have funded on youth development in their history. I have the good fortune with Terry Jernigan of running the coordinating center for this consortium. 21 sites across the nation, 20 states. Our sample is drawn from schools and communities, and I don't know why this is happening. We have over 500 investigators and staff who are studying 12,000 children, originally ages 9 to 10, and their parents. And the idea here is to match the national census on gender, socioeconomic status, cultural background, et cetera, and to follow these people over time, both with behavioral assessments, neurocognitive assessments, neuroimaging, and to link to external data sets that help us combine with information on the environment and a variety of other things. Now, you might ask, why is NIH, 12 different agencies within NIH and the National Science Foundation and CDC and Department of Education, et cetera, why are they coming together to fund this? Because so much has changed since 2000, just rapidly changed. Back then, about half of youth in the United States had a cell phone. Now, 98% have a smartphone. Although some things like drunkenness in the 12 to 17-year-old age range has dropped a little bit, there are other things that have markedly increased. Those things include depression, where at the same time other things have dropped, like school dropout, juvenile arrests, et cetera. So there are good reason to study this anew and in a very comprehensive way. So the one other thing I want to say to you as I start to give you some examples of how these findings from these studies apply to prevention and intervention efforts is it's a new model of doing research. That is, it's an open science model. Our data every year is added to a cumulative data set that's now available to the public. And when I say to the public, I mean anyone who's from an institution that allows you to do research, any of those researchers, not just across the United States, but around the world, are able to have access to these huge data sets that we have, longitudinal data sets. Right now, about 8,000 people from 38 countries have accessed that data. We have over 11,000 publications and over 250 grants that use these data. So the idea is to compress the time between when the science is developed and when we can use it for practical purposes. It can have some impact. I thought I would share with you a little bit about the types of publications that we do. They are in every area so far that we study, things like mental health, the imaging procedures that we have, physical health, neurocognitive performance, thinking abilities, as well as use of new technologies, and I'll give you an example of that. We have these linked external data sets that help us know about the environments that people grow up in, and we don't have to ask them about that. We take those from national data sets and link it to our data set. Now, in each of these areas, what tends to happen is that this is the first time when we've had such a breadth of information on individuals that even when we're studying mental health, we can find out about genetics. We can find out about the environment that they live in. We can find out about the neighborhoods that they're in and their physical health. So it's linking aspects of functioning in new ways. It's that information, I think, that can feed into our better understanding of what we should do by way of prevention and intervention. One example is we now have enough information on these 9 to 10-year-olds that we started to study that we can create national standards for brain development, some aspects of brain development. Just like when you were a child or have a child, there are growth curves in height and weight. We're developing growth curves in terms of brain morphology and functioning. It's the really important factor, because if something goes wrong in school, in somebody's life, we can see how is the brain related to those behaviors. And it can give us a picture or new pathways into how to help with that. That's particularly important for addiction, where we know some brain functioning features predate onset of addiction, but also are dramatically changed. Now, we've known that for adults in a long time, but we sure have not known that with adolescents. Another thing is that our neurocognitive assessment tell us how early thinking abilities relate to the emergence of certain behaviors and problems, like early substance use and addiction, and then we can develop interventions, not just in the healthcare setting, but in the school setting, on the basis of these thinking abilities and the patterns whereby people learn better and they learn more poorly. So you're not going to be able to intervene for an alcohol and drug problem with an adolescent if their thinking abilities are impacted in some negative way, and that's exactly the kind of way that you're trying to intervene. Good example, memory problems early on in treatment processes. If you ask people to report information after they leave a treatment session, and they're less than 3 weeks sober, then they are remembering much less than they will 2 weeks more out. So we need memory supports for those individuals when we're doing treatments, and we need to be sure that we're timing aspects of the intervention in a way that they'll be most effective. All right. Importantly, I think, and this goes to one of the earlier questions about differences in cultures and populations, these studies are helping us understand the role of culture and society in facilitating exposure to alcohol and drugs and progression once substances are involved. We're learning a lot about family factors here. Good example, during COVID, Black and lower SES families talked to their children more about COVID risks and what they could do to keep themselves safe. And the parents who did that had much lower rates of COVID in their offspring. Not as common in Caucasian families, not as common in high-income families, where the rates for COVID relative were much higher. So we're learning things we never expected to learn about prevention and intervention. Now, I'm supposed to talk about addiction today. When you first start to study 9 to 10-year-olds, I'll be honest, there's not much substance use there to talk about. But what we can look at and what can inform prevention are the things that are on the runway to early substance use or progression to abuse. So for example, 1 in 5 9 to 10-year-olds have already started sipping alcohol. Now, when I was growing up, it was assumed that people would try to sneak that. But that's absolutely not the case these days, that over 90% of those situations come from either a dad or a mom or a trusted family member offering drinks to youth. And most youth remember those initial experiences. And even though the base rates for actual full drinks is very low, it's like 0.5% in this 9 to 10-year-old age range, among those who have had a full drink, 3% of their friends they report as drinking already. So we see that there's extra exposure. We also know that they expect more positive things from drinking. We know that curiosity about alcohol and nicotine predicts not just to use, but we know who is at higher risk now for having higher rates of curiosity. And 1/4 of the parents in this age range said they don't have a rule about substance use. They've never talked to their children about nicotine, alcohol, cannabis, use of anything else. And Black and low-income families are more likely to have a rule to not use. And we know that having a rule in the family delays the onset. Why is that important? Because people who start to drink before age 15 are 3.5 times more likely in their lifetime to develop an alcohol or drug use disorder. So those early things about talking to your children are important. Now, most of that I've reported comes from that very large 12,000 family sample in ABCD. But because the Encanda study used 12 to 20-year-olds, we have people who've progressed into drinking and using. And one of the key things we're looking at is, how does this affect brain development? And one of the things we know is that adolescence is a time of very rapid neurodevelopment. Cortical thinning and myelination in white matter and gray matter reductions. So this slide shows shows first how gray matter decreases, brain gray matter decreases over the course of adolescence, more in earlier adolescence, and then stabilizes over time. But by contrast, white matter increases during this period of time. And what's white matter? It's that myelinated matter that helps, thank you, helps brains process information faster. And it's tied with the development of neural networks. So what we've been able to show in the Encanda study for the first time by following individuals over time is that the onset, that gray matter reductions accelerate with binge drinking. We've also shown that white matter increases that are supposed to be taking place are attenuated. That doesn't happen as quickly. There's a dramatic reduction in the rate of development of white matter and also in the integrity of the white matter that's developed. So this is really the first time where we've seen that early addiction or early extensive use of alcohol alone, not even just other drugs, but alcohol alone, can affect brain development. And what we're now looking at is how long does it take for things to improve when people stop? Boy, wouldn't that be important to know if you were an adolescent in school, and for your teacher to know how long is it going to take for you and what kinds of things will help your brain get back to normal with the cessation of binge drinking, as an example. We've looked at a variety of other things that trigger. I don't quite know why I'm having such a hard time advancing my slides. Sometimes it works and sometimes it doesn't. But we're looking at a variety of other things that influence this rate and pattern of brain development in adolescence, and including some microstructure features. But things like early trauma in people's life, how does that affect brain development? And then what implications does that have for prevention and intervention? These kinds of research studies can help us understand new behaviors like screen time for youth who are growing up now. For example, we have studied screen time use, time on social media, and looking at what are the effects of youth who are online a lot, things like future sleep problems, attention deficit symptoms, lower grades in school, fewer close friends. These are the types of things that we can find out in a study like this by using new technologies. In this case, it was an app that was on. I see my time is limited. I just don't know quite why I'm having a hard time advancing my slides. These are slides that information that we developed into infographics that have been sent out not just to all our families, but to professional organizations for dissemination, like the American Academy of Pediatrics, as an example, and the National Superintendents Association, to help guide parents in making decisions about supervision of screen time. For example, now we have a standard, 2 hours or more a day. Has accelerated risks for a variety of different problems. So one of the things that this is a good example of, and those additional problems include addiction, is that it used to take about 15 years between when we found something out in science and then there was actual practical application. And within 18 months of these findings, there are now national standards for this, and the federal organizations such as the American Academy of Pediatrics and American Medical Association now have standards. So one of the things about this open science is it can shrink the time from when we learn something to when we might be able to use it in prevention and intervention for offspring. So I think I'll stop here because I can't move my slides very well, and thank you all for your attention.
Questions for Sandy?
I can go again. So I appreciate the work you do. Again, I'm Gaurav Mishra. I'm a psychiatrist in the community. Appreciate the work you're doing. You know, I wanted to comment. This is probably one of the only times, could be because of my ignorance, but only times I've heard the advantages of somebody, like something that somebody in a lower socioeconomic status is doing that is having a positive impact on people's lives.
Yes.
And we only hear about, and which is true, that people don't have access to vaccinations or people don't have access to addiction care, which is all true, and we're working on those things. But it is really also very, I feel, when I heard you say that lower socioeconomic status families are talking more to their kids about COVID, and that resulted in less people having COVID, I feel like this should be, like, we should be shouting this on rooftops. This is really incredibly positive news. Same thing in alcohol. Like, if I heard that correctly, which is like so different than anything else we hear in addiction talks, I think I appreciate you sharing that. I'm going to tell people today where I work that this is different, and
Yes.
it is, and this is a way of thinking about strengths-based approach and like sort of empowering people with what they have first too. So, thank you.
Absolutely. One of the joys of being in a study that's this comprehensive in terms of youth functioning and the family functioning is that we can find some of these things that are culturally appropriate, that are very positive, that create both diminish risk and or create resilience for
Right.
those families. So thank you for noting that, and I've got a lot of stuff that relates to how those children are dealt with in school that
Right.
have come out from these studies as well. Same kinds of things.
Okay, thank you.
Yeah.
Thank you so much, Sandy. I learned a lot. I have a question. You mentioned about addiction, about the kids playing game, right? More than 2 hours, and also adults, or teenager addiction in alcohol or drug abuse and so on. Do you see any correlation for kids who are addicted to playing game later on? Somehow they will become addiction to drug or alcohol.
So there are some very interesting studies in this. Great question, by the way, GP. Thank you for asking. So I want to make it clear, all social media use is not bad. There are some kinds of games that actually look like, for children in this early to middle adolescent age range, increase problem-solving abilities, help persist with persistence in attention. I mean, there's some that do that. Other types of activities, though, accelerate a sense of isolation and differentness, or expose people to youth to images that normalize excessive use of substances early on. And so exposure in that way can accelerate the onset of substance use and progression to substance use. Now, when people are addicted to gaming, when they're doing that regularly, and I think we have some brilliant learning theorists who design those games so that they can, in fact, be particularly addictive.
Right.
And there is evidence that activation in certain regions of the brain, particularly the nucleus accumbens, during gaming, is a sensitive area in the brain associated with substance use dependence. And so we do think there are links. there are marked differences, of course, between doing something online and voluntarily taking a substance that you could become addicted to. But they both are initially voluntary behaviors. But the learning experience from the brain may have some similarities.
Thank you.
Great question.
Thank you.
Thank you.
Okay. Thanks, Sandy.